So today we're going to talk about popliteal aneurysms. We're going to transition over from aortic aneurysms to another form of aneurysm that we deal with. Remember, an aneurysm is an enlarged blood vessel. A true aneurysm involves all the walls of the blood vessel. There's three parts to the wall of a blood vessel, the arteries anyway. And so popliteal aneurysm is an aneurysm of the popliteal artery, which is the artery behind the knee. Now, if you have an aortic aneurysm, you have about a 5% chance of having a popliteal artery aneurysm. But if you have a popliteal artery aneurysm, you have a 50% chance of having an aortic aneurysm. So if you're diagnosed with a popliteal artery aneurysm, you need to be screened for an aortic aneurysm with ultrasound testing just to make sure that you have one or don't have one, as the situation may be. And then if you do have one, whether it needs to be monitored or fixed. But anyway, popliteal artery aneurysms are large blood vessels behind the knee. Typically, they're found incidentally when somebody's doing a physical examination on you. But a lot of times it's missed because nobody really, I wouldn't say nobody, but a lot of people don't feel the pulse behind your knee. Like people in my specialty, vascular surgery, tend to do that. Look for these aneurysms behind the knee. And so examination behind the knee, you feel this pulsatile mass. And then you suspect a popliteal artery aneurysm, you do an ultrasound, that confirms it. The issue with these things is they don't tend to tear open like aortic aneurysms do, but they can cause other problems, and so they need to be monitored most of the time. So the normal popliteal artery is about 0.8 to 1 centimeter in size, which is like yay big. And so if it's 2.5 to 3 centimeters, that's when you really start worrying about it more, especially if there's a lot of clot inside of these things, because that's what popliteal artery aneurysms tend to do. They don't tend to tear open like aortic aneurysms do. They tend to accumulate clot in the inside of that bubble, and some of that clot can break off over time, either in an acute event where you have an arterial embolus or clot breaking off and going down the leg, or it can be chronic in that small clots keep breaking off over time and leading to problems downstream. And so you can imagine, if a clot breaks off and heads downstream, it can cause a lot of problems because it'll hinder the circulation to the foot, and so you can get into situations of critical limb ischemia where the foot is at risk for limb loss because you can turn gangrenous. You can have gangrenous changes in your foot if it's not addressed quickly enough. But typically, most people don't know they have these things until it's discovered incidentally. And they don't really have any symptoms until an event occurs, like an embolus to the lower extremity, where they have sudden onset of pain in the foot, discoloration of the foot, and eventually gangrene, or the aneurysm itself, thrombosis or clots, and then you have the same thing. Poor blood supply to the foot, acute pain in the foot, very debilitating pain. You need to seek evaluation and treatment very quickly, because if it stays too long, there's irreversible tissue damage and a whole host of things. So anyway, if you diagnose with a popliteal artery aneurysm, it doesn't necessarily need to be fixed. I'd say about 5 to 10% of the ones that I've followed eventually need fixing. If they get bigger or if they develop a bunch of clot within them, then it's fair enough to fix it. But otherwise, most of the time, we can just follow them with ultrasound testing at regular intervals and just make sure they're not getting bigger. If they get bigger, there's ways of fixing them. So in terms of fixing them, there's two ways of fixing them. One is with what's called stent grafts, where we, just like aortic aneurysms, we put a stent with material sewn on it across it. So think of this stuff again like plumbing. Here's a plumbing in, plumbing out. This enlarged blood vessel there. You want to exclude it from circulation, so you can go in from the inside, put a stent graft across it to exclude that aneurysm from the circulation, so blood flow goes down the stent graft rather than going to the aneurysm. Then that's the endovascular technique. And there's pluses and minuses of that. It's obviously less stressful on you, but sometimes the results may not be quite as good in certain circumstances. Then there's open surgical repair, where we take your own vein. Hopefully you have a good enough vein, saphenous vein. We use that to essentially go above and below the aneurysm and and exclude the blood flow from going into the aneurysm. Either way, the results are really good. So to kind of summarize, not everybody has a popliteal artery aneurysm needs repair. It doesn't tend to tear open like aortic aneurysms do, but it can clot off or send clot downstream to your foot and put you at risk for limb loss. And so you need to be monitored. And if it gets a lot of clot within it, or if it gets big enough, then it needs to be consideration needs to be given for repair. And there's two options: the endovascular repair and the open surgical repair with vein material if possible. Very manageable disease, but it just needs to be diagnosed and monitored most of the time. Then there's other aneurysms that can occur: femoral artery aneurysms, the artery in the groin. Again, size criteria, clots, these all need to be monitored. Arm artery aneurysms, subclavian artery aneurysms, that's a little unusual. Typically involves thoracic outlet syndrome. I don't know if you remember years ago that Houston Astros pitcher, J.R. Richards. He had a repetitive motion injury from thoracic outlet syndrome. He actually had a stroke because he developed a subclavian artery aneurysm, and it embolized the back of his brain and caused the stroke. An unusual situation to have subclavian artery aneurysms, especially those from repetitive injury. We'll talk about TOS, the thoracic outlet syndrome, in a later date. That's one of the topics we should cover. So there's other sites of aneurysms. Somewhere down the line, we'll talk about spleen artery aneurysms, kidney artery aneurysms, intestinal, artery aneurysms. Again, infrequent findings, usually found at incidentally when testing for another problem, but we'll talk about that at a later date. But popliteal artery aneurysms, I think the key is they get diagnosed and they get managed, and most of them are managed conservatively and don't need repair. But if you have a popliteal artery aneurysm, you probably need to be screened for an aortic aneurysm because you have a higher risk for it. Next time we'll talk about the abdominal, the visceral, or so-called visceral aneurysms, splenic artery aneurysm, renal artery aneurysm. We'll talk about those things. And then we'll progress to other topics like carotid artery disease, dialysis access, thoracic outlet syndrome, and other things that are part and parcel of what we do, temporal arteritis. Those things we'll discuss at a later date. Hope you're getting something out of this. I'm trying to put it down on video, what I've learned over the few years, so that you'll have a better idea of what you're getting into when you are diagnosed with these conditions.